Anne-Marie, I hear, yeah. This is about PRISM 4. This is the study we didn't do, isn't it? Hi, good morning. Interesting. So why did I get this pushed to me?
Hey, Gail, can you go ahead and mute yourself unless you have a question for the group?
All right, we're gonna give people another minute or two to trickle in, and then we'll get started shortly. Okay, everyone? All right. Hi, everyone. My name is Steven Famulero. I'm a clinical research project manager here at the Children's Hospital of Philadelphia. Starting this year, myself and then Ryan Burnett, who's a fellow coordinator here with me, have taken over the chair roles within the PALISI RC network group. And we have our past chairs of Josie Hensley and Lexi Gertzen, who have started up these educational topics that we've been doing. And today we have PRISM 4 by Josie, who's a project manager at Nationwide Children's. She's also a part of the scientific review committee within PALISI.
Cool. Thanks, Stephen. So today we're going to be talking about PRISM 4 and dive a little bit into PRISM 3 since some sites still use that. So this will be data collection and scoring for coordinators. And like Stephen said, I work at Nationwide Children's Hospital in Columbus, Ohio. I did want to welcome the CCC-RCG. So for the PALISI folks that are on the call, this is our Canadian Critical Care Research Coordinators Group. So this is a subgroup similar to us at PALISI, but they've been around much longer than we have. They've been around for about 20 years, and we've been really fortunate to connect with them this year. And they're opening up webinars to us. We're opening up webinars to them so that we can just foster some collaboration and knowledge sharing and that sort of thing. They do peds and adult critical care research. So we're trying to make sure that we're only sharing, webinars that are appropriate to whichever group, we're a part of. So we won't be sharing their, like, maybe adult specific webinars and things with the PALISI group to not bog down your calendar. But so welcome to the CCC RCG, and thanks for those of you that are joining us today. I did want to just put out a little plug for our website, palisicoordinators.weebelieve.com. You can find information about upcoming conferences, upcoming events and webinars. There's a summary of what we have going on, contact information, and all of that. Okay, so we'll get started. So this is my first time using one of these, so I'll be curious to see how this works. And I'm not sure why this, first time, it's supposed to give you a QR code. See if that QR code in the top right will work for you. So I have a question, and we already have a question coming through. Yes, this meeting is being recorded, so we will have all of these up on our YouTube. So to start off with, yes, so see if this QR code at the top right corner works. It was supposed to be bigger than that. Yes, you're getting it, Amanda? So I'm curious to see, for those of you that are on the call, do you know why we collect PRISM data for PICU studies? Just, yes, I know why, no, I don't, or I think I might know why. And then supposedly the answers are going to come through on here. Shoot, it's not showing the live, and I wonder if it's because I'm not logged in. Well, shoot, I apologize. Like I said, it's my first time using this this feature. Okay, so then thank you for responding and being on there. So if you want to just put in the chat then how you responded, or chime in, yes. Let's see, CJ says it's not working. So much to learn. Thank you for being patient. So hoping to get a little bit of feedback. Some people say, I think so. Is it severity of illness? So we're going to get into some of this, but I just wanted to kind of take the temperature and see if people know why we collect it. Okay, and then let's see if this one works, if you even got it on your phone. So when you are using PRISM, how are you using it? So the first one would be, are you only collecting the raw data as indicated by a given case report form? Or are you also sometimes calculating, yay, this one worked, okay. Or you're also potentially designing case report forms that use PRISM data. So it looks like most people are just collecting it based on their CRFs. A couple of people, looks like, are designing CRFs with them. Awesome. Thank you for your patience with this. Okay, so we'll get into kind of all of this a little bit. I was helpful to know sort of the baseline of where people are coming from, because I think there's even people that have been in research for a while, PICU specific research, there seems to be varying degrees of how people use it, their knowledge about why we use it and that sort of thing. Because I think that all really plays into making sure that we're using an informed approach when we are collecting the data. So the pediatric risk of mortality is a physiologically based score used to quantify physiologic status, and when combined with other variables, it can compute expected mortality risk and expected morbidity risk. So what I like to say is it's one way for us. So I come from a bedside nursing background. As a bedside nurse, we can maybe be taking care of a patient or walk into a room, and we know by looking at the patient, we could sort of identify that one patient is sicker than another, but how do you quantify that? So PRISM is one way to quantify that a patient is sicker than another patient. So then why PRISM specifically? So as we mentioned, it's a quantification of their physiologic status or their severity of illness. So how to quantify that one patient is sicker than another. It is used to control for severity of illness in research studies. So let's say there's a large multi-center PICU research study, and we're collecting PRISM data. They could stratify those patients based on their severity of illness and control for severity of illness when they're doing their analysis. And PRISM is a predictor for mortality and morbidity. So I did just list here some of the other things that, some of the other scoring tools that we use in PICU data, right? So we're quite familiar with PLOD. FSS is becoming, the functional status score is becoming more frequently used, and PCPC and POPC, which are pediatric, cerebral, and overall outcomes, basically. It used to be in PICU research that we were really focused on, our outcomes was always based on who survived and who didn't survive. As we've gone along in research in the past several years, we've realized it's not really just about whether a patient survives or not. It actually really matters, are they back to their baseline? Can they get back to their baseline, or are they having lingering deficits? So that's why we're starting to see more of the FSS, PCPC, POPC, that kind of thing, because they tell us more about quality of life type of measures after discharge. So anyway, so PRISM is specific to ICU admission. It's a predictor of mortality and morbidity. PLOD is organ dysfunction. It's an organ dysfunction scoring tool. It can be used, it's also like a severity of illness type of thing. But if you guys can make sure that you're muted, that would be helpful. And I did forget to mention also, if you have questions as we go, please feel free to put them in the chat or chime in. This doesn't have to be me talking the whole time. I'm interested to see your feedback and that sort of thing as we go along. So anyway, so I just wanted to put out there that there are different scoring tools and they are used specifically for different things. So based on the study that you're collecting for, that's why you might see one versus another. Because for one study, organ dysfunction might not be the thing that they're looking at, but there could be different measures.
That's nice.
So some things to consider as far as timing and other things. So the two most frequently used versions of PRISM that we see today is PRISM 3 and PRISM 4. So PRISM 3, I believe, came out in the late 90s, and PRISM 4 in maybe 2015, 2016. And they are, well, they both use the same essential criteria, so the same vital sign components, the same lab values. There are some minor differences that are important to understand, particularly if you're one of those people that you're building a case report form based off of PRISM, if you're calculating PRISM scores, that sort of thing. So the PRISM 3 is based on a 12-hour window. It's like the PICU admission time plus 12 hours, whereas the PRISM 4 is a 6-hour window around PICU admission. So your physiologic variables, your vital signs, those are only in the first 4 hours. Lab values, they specify you can actually backdate up to 2 hours before PICU admission, so you can get things that were obtained in the ER and that sort of thing. Similarly, PRISM 3, another difference is that PRISM 3, you could calculate based on any PICU admission. So if a patient, during a hospital stay, so if a patient kind of bounced back and forth from the PICU to the ward during a hospital stay, you could essentially collect a PRISM score, a PRISM 3, multiple times. In PRISM 4, then, they adjusted that score, and it's only the first or the index PICU admission is actually applicable. So these are just important things to keep in mind. I will say, part of what has, prompted us even talking about this and things is that over time, so I've been doing PICU research for almost 10 years now. And it's really only been even like designing case report forms during that time. But I think for the first probably like 7 or 8 years, I actually had like very little knowledge about like some of these finer details. And so we were, as a team, like we'd be building a case report form for a new investigator initiated study, and even a multi-center study that I run now. And I approached our PI in the last year and I said, you know, actually the PRISM that we're collecting for this database that we have running, it's actually kind of a hybrid of PRISM 3 and PRISM 4, because I didn't understand some of those nuances when I built this. So even I'm still constantly learning, and there's very much like a learn as you go sort of thing. But I think if anything that I've learned is, in the past couple of years, is to always go back to the source. So whether you want to learn how to collect data better, whether you're helping to build a case report form that's based on these measures, you need to specify with your PI, do they want the PRISM 3 or do they want the PRISM 4? And then actually go back to the published data. And I link at the end of these slides the actual like published PRISM 3 and PRISM 4, because those should really be your gold standards for going back and making sure that you are collecting the data in a way that matches the validated tools. So one note that I have here is that sometimes we do see that an investigator might choose to use PRISM scoring differently than how it was published. For example, we have a study through our institution where for that given study, they actually collect the PRISM at it's a PRISM 4 essentially at 2 different time points. And so they've chosen to do that just because of some other things that they want to look at. But the PRISM is only validated to predict mortality when it's used according to the guidelines of the published data. So always important to just talk with your PI and see what it is that they want. But it's also good for you to understand what the standards are, what that validated tool looks like, so that if somebody comes to you and asks you to do something a certain way, you can say, oh, but did you know that X, Y, and Z? I can't tell you how many times I've sat down with to help design a case report form with an investigator. And because I have some of that background knowledge, I can help kind of guide them in, well, did you think about this and did you think about this? And they might still want it done differently, but at least then you would know to help kind of guide that conversation. Oh, and I just highlighted here these, you know, a lot of times we see now that we kind of combine these together. I've seen this a lot in databases where we use that full 6-hour window for the physiologic variables and the lab values, but the physiologic variables or the vital signs are really specified in the published data from the PICU admission to 4 hours. So those should not, according to this, be backdated the 2 hours before. It's only the lab values that can go back. This is just like a quick overview of PRISM. This is something that I specifically put together. This is not from the published data, but it was like sort of a summary that I came up with. So it just helps to sort of lay out what the different variables are per age group, and then what that scoring would be. So I did want to go through some of these different data collections and talk about really what the guidelines are and some things you want to think about when you're going to be collecting this data. So the PRISM is a sort of, it's not an organ dysfunction tool, but they do sort of categorize it by organ system. So for the cardiovascular system, when collecting the lowest systolic blood pressure, they don't really specify a method of blood pressure. So you could infer that getting the lowest value from either an extremity blood pressure or an arterial line would be appropriate. Again, it can be PI or study specific. They might say, but we only want arterial or something, because they might want it to be consistent. So either all arterial or all cuff. But per the published data, they do not specify, so either one would be appropriate. And then to note with the highest heart rate, they do specify that they do not want it collected during crying or iatrogenic agitation, which would be agitation that's caused by medical examination or treatment. This is something I see all the time when collecting data. This is like a very frequent, like new to PICU data collection, right? We know that from a clinical perspective, typically we run cares to our patient, right? So typically that involves for a baby, changing their diaper. Most of our patients are getting suctioned every 4 hours. So we're going in there, we're beating on their chest, or they're getting a vest treatment, and then we're suctioning them. We are causing them to cry and scream and wail, and their heart rate is going to be probably in the 200s. So that's just something to consider, like know your clinical team's, their typical standard care time, right? So for example, here, this would be an example of an elevated heart rate due to agitation. Can I say 100% for sure? No, I can't really say 100% for sure. But knowing the routine of my hospital, when we do cares, and looking at the trajectory of their heart rates for the day, I can, with a very high likelihood, guess that this is probably during agitation, because I know that at my institution, cares are typically done at midnight, 4 a.m., 8 a.m., noon, and so on. So when you see this like very consistent set of heart rates, right, ranging between the 130s and 150s, and then this like just way out of line one, and it's right at midnight, and then so I can be like, okay, they're probably doing their chest physiotherapy, suctioning this child, that sort of thing. It's not just because it's out of range like that doesn't always mean that it's incorrect. So if there's something like that that you're just not sure, it's always a good idea to check physician notes, check nursing notes, because if there was something going on that caused like a sudden increase in their heart rate, it would probably be documented in some other kind of way. You'd probably see something else. But for a situation like this, my practice would be I would not document this heart rate of 194 as my highest heart rate during that given time period. What you should do, though, is make a note on your case report form or somewhere else for an audit trail. Because if an auditor was to come back to you and be like, well, why didn't you document this? You should have a note somewhere showing, did not document, actual highest heart rate documented was 194, presumed to be agitation during cares or something like that, so that you have an audit trail and there's something that like makes sense. Also, if all else fails, check with your PI. Your PI should be your gold standard always if you have any questions. I would say the vast majority of PIs are clinicians. They are attending physicians, and so they should be able to give you some guidance on this. But this would be, that's how I would approach documentation like this, so that we're not documenting iatrogenic heart rate elevation. Oh, and I'm just highlighting the midnight there. So when you're trying to figure out if documentation in the EMR is actual or artifact, there are some different things to consider. What's the consistency of the data? So like we showed before, you get a very consistent set of heart rates and then just one wacky one out of the blue. So is there some consistency? Is there like a trend up and a trend down? If there's like a trend up, that's probably my patient's having some actual physiologic changes and they're getting worse and worse and worse. And then maybe they gave a medication and it's getting better and better and better, right? So if it's a truer vital sign that's documented, we'll probably have more of that steady incline and decline versus like a one-time out of the blue sort of elevation. Like I said, know your routine cares and when those are done. Are there other notes or documentation that provides a rationale for such a drastic physiologic change? Something to note, just because something is documented in the EMR does not mean that it's accurate. Bedside nurses do this all the time. Most of our vital, like our monitors where we're, with the heart rate and the blood pressure and oftentimes even the temp probe, I would say for most institutions, that automatically now pulls into our EMR. So as a nurse, we're not actually going through and documenting all this stuff. It's pulling directly from the monitor into the EMR, and we're just verifying. We click a verify button to basically chart it. Well, oftentimes we're doing several hours at a time, and people go through and they go verify, 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 but they're not actually looking at every single component and making sure that it makes sense. That's why you see a lot of things in the EMR that if they did manually type it, maybe it was a typo, or maybe they verified because the monitor actually picked up a heart rate of 250 while the baby was crying. But that doesn't mean that was like a physiologically like accurate heart rate. So just be thoughtful of like, just because it's in the EMR does not necessarily mean that it's accurate, and it's okay to question it if it doesn't make sense. And like I said, if you choose not to document a value that was from the EMR, make note of it on a CRF or an auditing trail. Okay, so neurologic status. Really the biggest thing to note with neurologic status is that the PRISM does specify that we don't want to document the mental status, so the GCS score, if it was within 2 hours of sedation, paralysis, or anesthesia, because we know that that is going to decrease the score, and it's not going to be really a true score of what the mental status is. This PRISM is really trying to get at patients with an actual like neurologic component to their disease process, not our medical intervention, through medication. So, and if a patient does have like a continuous sedation or paralysis, if there's a time period that during that PRISM window without sedation or paralysis, you can go ahead and use that score. Otherwise, if it's continuous throughout, where all of the scores documented are within 2 hours of sedation or paralysis, then you should have a way to mark it as like not done or leave it blank. And then for the pupils, make sure, I don't think that it's, not all documentation or not all CRFs really specify this. It says pupils fixed and dilated, right? So it's one pupil fixed and dilated or both pupils fixed and dilated. And sometimes we get the question, well, what does dilated mean? What is specified as dilated? And in the published data, it does say for greater than 3 millimeters would be dilated pupils. So if it's a fixed but not dilated, so if it's a lot of times a patient that's on paralytic medications, they will have fixed pupils, but they will be fixed in pinpoint. So they will be fixed in one, right? So you're not going to score them. You're not going to select one pupil fixed and dilated or both because they're pinpoint. They really should be fixed and dilated in order for that to count. Temperature, they do specify that you can use rectal, oral, blood, or axillary temperatures. It doesn't really specify. Sometimes we get temperatures from the bladder. So a patient that has a probe with from a catheter or something, that would be a situation that you might want to check with the PI or the team to see if that's an exception that they would want to make, if that's the only temperature that you have. But what's in the actual publication is one of these four sources for your temperature. The biggest thing that we see, actually, this is probably across the board one of the most common one of the most common data queries that I give and mistakes that I see across the board is related to temperature. A lot of our patients in the PICU have a temperature probe that goes into their rectum, or a temperature probe that sometimes we will actually tape under their armpit. So we're collecting essentially a continuous temperature. If that probe comes out, like I said, when we go through, we're just clicking verify, verify, verify for our EMR data. But if that probe has come out, we might still be verifying a temperature that's not actually a real temperature. It's actually essentially taking the temperature of the air. So similar to what I mentioned before, you know, look for steady inclines and declines and look for a physiological rationale for extreme temperatures. So this is an example from a chart where a probe came out, and so you have consistent documentation of a temperature of 37 degrees Celsius, and then you have like one out of range value at 21 degrees Celsius. I can assure you that it is physiologically impossible for a patient's temperature to drop from 37 to 21 and back up to 37 within a time span of 15 minutes. So just keep that, again, keep that in mind. Any temperature really less than 30 degrees Celsius should be questioned and assessed for validity. Even amongst the sickest of the sick ICU patients, that is going to be incredibly rare. Typically, if you're seeing a temperature less than 30 degrees Celsius, there really should be some other very clear documentation confirming why it's that low. You might see that in patients that are being cooled post-arrest, or if a patient is in the operating room and they're being cooled for a procedure. Those are typically going to be the times when you see a temperature that's that low. And this is just from, this is a screenshot from EPIC. Again, just kind of showing what that trend would look like looking at the temperatures kind of longitudinally like that. All right, so the next section on the PRISM is looking at acid-base balance, looking at the blood gases. So there are various components from the blood gas that we look at. The pH, total CO2, PCO2, and PaO2. And so I'll just go through kind of a few of the key takeaways from those. So your pH on a PRISM score can be collected from an arterial, capillary, or venous blood gas. Same for your PCO2. So all of those can be collected from arterial, capillary, or venous. I'm skipping the TCO2, I'm going to come back to that in a second. The PaO2 should come from our arterial blood gas only. So the non-arterial version of that would be like PO2 is how it should be reported on your blood gas. But so you'll only be collecting that from an arterial line only. The TCO2, they do specify they want this preferably from a chemistry. So this would be your bicarb on a chemistry. But then if it's not available on a chemistry in that time frame, then you can actually go back and collect that as the TCO2 on your blood gas. So that's where that one can get kind of a little bit confusing at times. One thing to note is that blood gases in your EMR might actually show up in a couple of different places depending on where it was collected. So you can collect a blood gas at the bedside. There are these point of care test machines that we can use and actually run those labs at the bedside. Or that test might have gone down to the regular clinical lab. And so based on where it was done, they actually might result in completely different places in your chart. So just note that, like have that in the back of your mind. And if you're not sure where those are, like connect with your clinical team, maybe like the nursing educator on your unit, another nurse on the research team, or of course with the PI or attending. They should be able to tell you where these things can be found. So the chemistries that we're collecting are glucose, potassium, creatinine, sorry, I've got a question here. If an arterial blood gas is not available, can PaO2 be imputed using SpO2 conversion chart? That's a great question. It's not that is not specified in the data, in like the published PRISM. They don't do that. I will say from that's not something that I have seen done routinely for any studies that I've been a part of. But certainly that is a question that you could bring to your PI or the study team that is collecting it. But I would not recommend routinely doing that. That's something that I would recommend checking with the overseeing PI about. Let's see. So some of your chemistry values, remember how I mentioned that we have bedside point of care testing that we do? So sometimes those machines can actually run different chemistry components. Sometimes they will run a full chemistry. Sometimes they will just get the lactate. Sometimes they will just get a glucose or things like that. So just be aware that your chemistry values as well can be in various places. So they might be in the chemistry section in your lab. They might also be under your blood gases. So if you're in your EMR, you actually should be looking under your blood gas section when you're collecting chemistry data, because they could be reported there. And actually, they, at least at my institution, they often are. We often run a chemistry or various components of the chemistry in the blood gases. Glucose is another one that, depending on how it's run, because there's a separate glucometer that could run your glucoses, and that again might report in a completely different place. So know where all these various places are and check all of these various places, because you should be collecting the highest or worst values from all of these available potential sources. One thing to keep in mind with chemistries is that sometimes they will actually be hemolyzed, and so they'll be essentially artificially elevated. So something to note, this is not something that's specified in the PRISM published data, so you should always check with your PI, whoever's running whatever study that you're collecting, on any guidelines that they have specifically for your study. But in general, you should exercise a lot of caution with documenting results from hemolyzed labs. We see this most often with potassiums. And potassium is one of the components of the PRISM, right? So I believe it's potassium greater than 8, or sorry, 6.9. So potassium greater than 6.9 will actually give you points on the PRISM. Well, if you have a hemolyzed potassium that shows up as 7.3 would otherwise, but it's a hemolyzed value, you could potentially be giving a patient PRISM points when their actual blood potassium is not at that level. It's because it's a hemolyzed blood sample. So just keep that in mind. Like I said, you know, I'm not going to say totally do or don't document it, but just keep that in mind and consult with your PI on whether or not you should actually be documenting that in the data.
Rosie, I'm just going to pause you for a second. Yang Mai, I don't know if you can hear me, but your microphone is unmuted and we're hearing a lot of background. So if you wouldn't mind muting your mic. Thank you.
Thanks. Hematology, I guess the biggest thing to say here, again, similar to the chemistry, this is not in the PRISM published data. This is just something that you should be aware of, whether you're collecting hematology for PRISM or really anything else. But essentially, over the last 10 years, what I've been told consistently is to avoid documenting hematology values from those point of care testing mechanisms, like an EPOC or like those other point of care. Again, the blood gas sample from a bedside point of care test thing can often collect hematology. And I will say from a clinical perspective, we typically use the hematology values more as trends. If we want to know a true hemoglobin on one of those, we will send that down to the lab and not do that on the point of care testing. So again, it's not a hard and fast rule by any means, as opposed to chemistry on the bedside point of care testing are usually pretty accurate. The hematology, they're calculated values. They're not like nearly as accurate as an actual hematology. So that is one thing that I would say, while you should always like know and understand all of your sources, those are, you should generally avoid collecting those from that point of care. So not in your blood gas section with everything else. Some general like scoring tips if you're somebody that is going to be doing scoring or even setting up your data for a statistician or somebody else to do your scoring. Oh shoot, I think it just stopped sharing. Can you guys hear me still?
We can hear you. We just can't see the screen, or at least I can't.
Thanks. I'm not sure why that stopped all of a sudden.
Probably has a limit on the time.
All right, give me just 1 sec. Because it even stopped my, like all of my video and everything. All right, I'm gonna try one more thing. So I disconnect from my second monitor. So it looks like somebody else took over as the host. Stephen, you mentioned that, but I don't see that anywhere. Do you see
It's
who took over?
Katrina. Looks like Katrina is the host now.
I don't know why I'm the host, but I can try to get that back to you, Josie.
Give me host status, please. Yeah, I'm not sure how to take that back.
Yeah, let me try to figure it out. No?
Josie, if you go on the top screen and go to participant, there's an option to reclaim host role.
Yeah, I don't see that.
I'm like not sure how to do this either.
Yeah, because on my screen, it still shows me as the host.
I see how it says host for me, but I'm not sure why that is.
It's telling me that I'm no longer connected to the meeting. It's automatically reconnecting me. I wonder if I'm having,
Oh, Josie, at the bottom of your screen, there should be three
Yeah.
little dots. Like next to
Yeah.
the hand up and the smiley face, click on that, and then you can reclaim host role.
yeah, it's not showing that at all for me.
I don't get that option under the three dots. I only get that option if you hit participant up at the top left, and then you have the option to do like mute me, reclaim host role is where mine shows that.
I have no information on how to like not be the host.
Yeah, no, it's okay. It actually just kicked me off of WebEx entirely. I'm connected through the voice on my phone, but on my computer, it just kicked me off entirely.
Do you want to send me your slides and I can just show it as you talk?
Yeah, that would be great. Thank you. Okay, well, in the meantime, I'll just keep chatting though. I apologize, we don't have the slides. So a couple things to keep in mind with scoring and billing a CRF with the plans of somebody at some point doing the scoring. Make sure that you're setting up your data collection in such a way that you're able to adjust for certain things such as sedation or paralysis. So again, when we think back to the neurologic scoring, there might be times that you'd still want to know what the GCS score is. You know, within, you know, was it less than 8 or, you know, greater than 8 or whatever range you guys you're setting up. But just make sure that there's a way for your users to actually then indicate whether sedation or paralysis was being used, so that whoever's doing the scoring can make sure not to give them points for their neurologic status if that GCS was falsely low from our sedation. There are also a couple components within PRISM that could potentially lead to double scoring. So for example, the temperature, a patient would either get points for a temperature of less than 33 degrees Celsius or greater than 40 degrees Celsius, so, but not for both. So that's an error. Actually, I was working with one of our statisticians at Nationwide who'd been using our code that had been developed and used throughout the hospital. So not even just our department, but used through the hospital for various, like for PRISM scores that other people have been using. And when I was going through her R code, I realized that they were potentially double scoring. So if a patient had both a high and a low, or if it was documented in, you know, in both places, they could actually end up getting scored twice for that. So that's just kind of an alert area. Similar to in the acidosis section of PRISM, there's acidosis scoring, which would be a low pH or a low TCO2, so it's one or the other. They should not get scored for both, but it can get confusing because then right below that, for the alkalosis, you could get, there's like a specific section that's just for an elevated TCO2 and just for an elevated pH. So just pay close attention to those scoring mechanisms and how you're documenting it and all of that, so that you're setting up yourself for success with future scoring. And I think my biggest tip, in addition to always making sure that you're going back to the source, right? So always go back to the original published data when you're building these things to make sure that you're catching all of those kind of fine-tuned things and not going off of, don't even go off of stuff that I've given you, I would recommend, because I've made errors in even things that I've used for myself or given to other people. So you can use that as like a starting off point, but always go back to the published data. But aside from that, I would always recommend, if you have the option of using a statistician or somebody who can build out code in a program like R, and then you can actually like validate and test several subjects, you know, using the R code and then you scoring it manually. This helps to really give you reproducible calculations. I've done this a lot with trying to do scoring in Excel, which can, you know, I can score 100 patients pretty quickly in Excel for PRISM. But I'm also, again, I'm relying on myself every single time to not make mistakes. So the more you can work with really like kind of a programmed, something like R to do this and test it and validate it, and then you can just use it time and time again. So those would be really some of my bigger tips with that. I'm still seeing if I can connect, but I can't seem to connect. Really, I only had a couple of slides left. One of them was just looking at, you know, potential like data collection design, specifically in REDCap. For some PIs, they're fine with sort of we just want to know what score they got. We don't really care what the raw value was. And then other PIs are going to want to know what the raw value was behind it. If you have the raw values of, you know, rather than just saying, oh yes, check, they had a heart rate of greater than 225, they get however many points that is under cardiovascular. It's easier to query that data if you're actually entering the raw value than to query a range, essentially. But again, it's PI, it's study dependent, so just but keep all of those kinds of little things in mind. I will send out the slides when we hop off the call, because I do actually have the references for the PRISM 3 and the PRISM 4 and a link out to the PubMed, because like I said, those, I would recommend anybody that's collecting PRISM or building CRFs with PRISM to actually like have a chance to look at these. I just think that they're, it gives you really kind of like the most knowledge and understanding to make sure that you're doing it in a way that's validated and to actually like understand the published data kind of behind it and that sort of thing. And then the last slide that I have was just some upcoming events that we have. So like I said, we are working with the CCC RCG to really kind of expand our webinar access. So they have a webinar on February 21st at noon Eastern on respiratory support. And then the following day on the 22nd, Ryan Burnett at CHOP will be doing the next PALISI one. And that's really RC Organization 101. So that one I think will be kind of cool, especially if you're a newer coordinator or even an experienced coordinator that might be considering taking on multi-center studies, or just kind of wanting to expand what you're doing. That organization component can be really helpful. So that's the February stuff that we have coming up. Like I said, I'll send out the slides and send you a screenshot in particular so that you know what the upcoming webinars are that we have. I've sent them out, like the calendar invites out, but if for some reason you didn't get them, you can send us an email at palisicoordinators@outlook.com. We're also super eager to know if you have any topics that you really want to hear about, or if you're interested in becoming a presenter. If you have like let's say you have sort of like a niche topic that you feel like you're kind of an expert on and you'd really like to share, something about, we'd really love to hear from you. And we do have some things scheduled all the way out through May. So I think we've got a lot of kind of good topics and things coming up. Ryan and Stephen, anything in the chat that I'm missing, and any other questions from anybody?
Hey, Josie, it's Debbie Spear. I actually do have two questions. One, and partially because I do all the VPS, well, some of the VPS data here at our site. And I know that, and I don't know if you mentioned this or not, but if their patient is being cold, like hypothermic on purpose for clinical reasons, those low temps usually should not be included in your PRISM score.
Thank you. I did not mention that.
I didn't know if you found that, because that's just what we're told with VPS. And the other thing with VPS, and again, I know VPS isn't the gold standard of everything, but also for PRISM 4 is you can use the 2 hours prior if they're like in PACU and ER or anywhere, except you're not supposed to use the OR values. And I don't know if that comes along with the fact that like with labs, like if a kid comes back post heart and your coags are all off because they were on pump and things like that. But it's just not to include OR labs. I don't know if you found anything.
Yeah. So I will say, so in terms of the cooling, I'll have to go back and look again. I don't recall seeing anything specific about like in the actual like literature where this came out about that sort of guideline, like about not using a temperature if they were actively being cooled. But that does make sense, and that's a very good point. And I'll go back and I'm going to look at a couple of these, like you mentioned, because even if it's not in the published data, these are things that are like really important to keep in mind. And similar to like the OR thing that you mentioned, I think for every study, that is something that we ask the PI about. Like, do you want the OR data? Because there are some PIs and for some studies and for some databases or whatever, that they don't mind and they might actually want the OR data. And then there are others that say, oh, no, we don't want that at all, because like you said, it really mucks up. We're basically taken over them physiologically. So like nothing, very little especially if they're under cardiopulmonary bypass. You know, there's very little that's like actually them. We're doing so much of the work for them, you know, and the coagulation, that kind of thing. So like I said, I don't recall seeing those specifically in the published literature, but I will go back and double check. But those are, yeah, like I said, super, super important things to keep in mind and to ask your PIs and your teams about, so you can make sure you're getting the best quality data. Any other like questions or comments?
This was helpful, Josie. Thank you for putting it together.
Oh, good. You're welcome. Yeah, I hope you guys find it helpful. I'm like such a data nerd, so this is like right up my alley. But so I'd be curious to see, you know, what is helpful, what isn't helpful, and what you guys would like to have, you know, kind of moving forward too. All right. Well, thank you, everybody. Like I said, I'll send out the slides so that you can get those kind of last couple slides, especially the references and upcoming webinars that we have. Thank you so much.
Thank you, Josie.
Thanks, Josie.